Hello, class of 2024. I'm so excited that we get to meet in person again next year. A lot of what we offer at the Radiology Interest Group is much more effectively pulled off when we're able to meet face to face and chat during or after the lecture. Besides, you all seem like awesome people, and I really look forward to getting to know you all. I do have two exciting announcements before we dive into this lecture today. First, I know I've had a handful of classmates from this class and previous classes reach out to me with interest in investigating interventional radiology as a future specialty choice. Up until now, we really haven't had too much to offer on that front, but EJ will be stepping up to act as our IR chair for the Radiology Interest Group, and it sounds like he has the drive and the vision to get our group connected with IR docs and help our classmates get connected to and interested in the IR world. So if you're interested in IR, if you know an IR doc, or otherwise want to help EJ pioneer this much needed section of our group, get in touch with him. There's more coming on this, but we will allow it to pan out as it goes. I'm really excited to see where this winds up taking us. Second, the Radiology Interest Group now has a new vice president. She has been incredibly active in the group since I think the very day she joined, even going so far as to set up and host a series of lectures for the M1 class in her first semester while I was nursing my sick third trimester wife and subsequent NICU baby. She has an incredible vision for the future of the group that doesn't conflict with, but really complements the group's current vision. She wants to expand what we offer to our members who are specifically interested in radiology as a specialty. And from what she shared with me, she has a lot of great ideas to get us there. So I want to welcome Annalise Silva as the Radiology Interest Group's new vice president. I'm really excited about this promotion, and I can't wait to see what the Radiology Interest Group can become in the next few years with her as its vice president. The video you're about to watch is the final review session that was provided to the class of 2023 when the M1s then took Staying Alive. It's about 45 minutes longer than we initially were hoping for, but I had a number of classmates reach out to me afterwards expressing that it really helped them to be able to enhance their skill in reading imaging. I would recommend that you play along and try to answer the questions as the lecturer is asking them, as really that's the way that these sessions are supposed to work live and will give you the most bang for your buck. Anyway, without any further ado, I hope that you enjoy this lecture, and I look forward to seeing you all as M2s at next year's lectures. Good luck on the final exam. Everyone, thank you all for being here. We have wanted to do this for a little while now. Dr. Vanderberg has done a number of presentations for us in the past. I particularly like his style because he kind of quizzes us on things and kind of makes it interactive. So we welcome you all to bring up any questions you have or to interact with us with the questions that he brings up. And I will just turn it over to Dr. Vanderberg now.
Okay, so it looks like we've got a fair number of people. So what I'm going to do, Aaron, it's difficult for me to pick people out. Well, actually, it's not, but I'll let you do it anyway.
Sounds good. Okay.
So we'll go ahead and we're going to start with cardiology, and then we'll do kidney and lung. So it's 1 o'clock. I will watch my watch closely. Okay. So I'm going to go ahead and start, and I hope everyone can see my mouse arrow and can hear me. So in cardiac, I'm going to talk about normal anatomy on a chest x-ray and some other modalities, as you can see there. I'm going to talk about pulmonary vasculature, which is actually quite important. A lot of people don't really key in on that. Cardiac size, once you see hundreds of chest x-rays, or even maybe 10 or 15, you'll realize what's normal, what's not. And then some basic pathology. Okay. All right, so for acquired disease, these are ones that you obviously aren't born with. Congestive heart failure is number one. You will see many cases of congestive heart failure. In fact, if you see an older patient, older than me, I am 61. So if you see anyone over the age of 60, first thing that should come in your mind on a chest film is, do they have congestive heart failure? Because that is very common. People will think that pneumonias are more common, but they're not. And then we'll also talk about hypertrophic and dilated cardiomyopathy. Okay. And then we're going to talk about congenital disease. Congenital diseases can be divided into basically two types, and they're the types of shunts that occur. A left to right shunt is fortunately much more common than a right to left shunt. Left to right shunt, for a classic example, is a ventricular septal defect, which is a VSD, where the blunt gets shunted from the left side to the right side when it's not supposed to be. So PDA is patent ducted arteriosus, atrial septal defect, and then you can have atrial valve septal defect. Now, right to left are the cyanotic lesions. I'll show you some of those. Tetralogy of Fallot, Epstein's anomaly, overriding. I'm sorry, not overriding, but transposition of great vessels. And then Eisenmenger syndrome is something that you should just know about. It's kind of an unfortunate syndrome. If someone has a left to right shunt that lasts too long, the pulmonary vasculature gets quite hypertrophied, and then the shunt will actually reverse, and you'll end up with a right to left shunt, and becomes a cyanotic problem. And this can happen to people in their 20s and 30s that have had an ASD or VST and no one knew about it. So it's a problem. Okay. Let's go. Okay. I'm going to go over normal here. This is a normal heart size. The transverse measurement from here to here is 1/2 of the entire measurement across here. Okay. This is aortic arch, descending aorta. These markings right here are pulmonary vessels. And most likely these are pulmonary arteries, but you also have pulmonary veins in here as well. This air density here is the trachea. On the lateral view, this is a normal sized heart. Inferior vena cava comes down here. Back up here, you actually have left atrium, left ventricle. Right ventricle sits most anterior. And I'll be reviewing this on a CT scan. And here's a nice little outline of where everything is. So on a frontal view, you really don't see the right ventricle. You'll see the left ventricle sitting out here. Whoever did this drawing should have made it come all the way out here, but they didn't. That's okay. And then on the lateral view, you'll see the right ventricle sitting way out front, and then way back here next to the spine's left atrium. And this will become important again when I ask you which chamber is closest to the spine. It's left atrium. Which chamber is closest to the sternum? It's right ventricle. Okay. All right, Aaron, you get to pick someone and make sure that I can hear them, that their microphone's on. I'm going to ask them some anatomy questions.
Okay. Well, I'll just go right down the list so I don't wind up picking on someone over and over again. So I'll just start here with Ahmed.
Okay, Ahmed. Can you hear me?
Yes, sir.
Okay, good. So what kind of studies are these right here?
CT scans.
Good. Excellent. Excellent. And does it have contrast or no contrast?
No contrast.
And if you had another choice?
Contrast. Yep.
Contrast. Very good. Very good. So, and don't worry, Ahmed, I know that you haven't seen a whole bunch of CTs, but the reason I ask this is if I just keep, asking a lot of repetition, I find it a very effective way of learning. So I certainly don't expect you to know a lot of these things, but it makes the learning a lot more durable, so to speak. So the reason why it has contrast is because this structure here is really white, and so is this. Do you have any idea? Let's go to something simple here. Actually, there's nothing really that simple here. What's the structure here?
Oh, that's the spine. I'm sorry.
Yeah.
I didn't see where your mouse was for first.
Yeah, that's a vertebrae. Good. Excellent. So sitting right in front of the vertebrae, this is a tube where food goes down, is what?
That's your esophagus.
Good. And then right in front of that where you breathe, what's that?
That's the trachea.
Excellent. All right. So what's this big guy here that's lighting up?
Would that be the aorta, ascending?
Excellent.
Maybe?
Aortic arch. It's aortic arch. Top
Sure.
arch. And this over here is a venous structure. It's a big one.
Superior vena cava, I guess, since we're looking down.
Yes. Perfect. Okay, good. Excellent. You're doing great. So, so this is coming down a little further. Okay.
Mm-hmm.
So what is this structure here? And this is the same structure.
So that's the ascending and then descending at the bottom, and then the pulmonary arteries, I want to say.
Yeah, main pulmonary. Now you see how wide that is?
Yes, sir.
That's too wide. It should be less than the aorta. So that's too wide. So this person actually may have pulmonary artery hypertension.
Okay.
Okay. And then this structure right here is what?
That's still the superior vena cava?
Excellent. Very good. Good job. Okay. So now we're getting a little lower. Who's next, Aaron?
We'll go ahead and go on to Alex.
Hey, Alex, you there?
Yeah. Hey, how are you?
All right, Alex, you there?
Hello?
Yep.
Can you hear me?
Can you hear? Yes, I can hear you. Can you hear me?
Yes. Yes, sir.
Okay, good. All right, and you see this image right here. So this is a CAT scan. It's a little lower. And what's this big structure right here that I'm circling?
Liver?
Okay, a little bit higher than that. Remember, in the chest. I tell you what, this structure pumps all your blood.
Oh, the heart.
Yeah, it's a heart. Yeah. So that's a heart. How many chambers do we have in our heart?
4.
4. We do. Okay. And what are they?
Left atrium, right atrium, left ventricle, and right ventricle.
Okay. Now here's the $1 million question. You see this chamber here? Closest to the spine. So you got a 1 out of 4 chance of getting this one. What chamber is that?
Left ventricle.
So left ventricle is over here.
Okay. So.
Excuse me 1 second.
You're
Just a second.
good.
Hey, I'm in the middle of a conference. Can I call you back? All right. Okay. Okay. So this is left ventricle. I'm sorry. So what is this?
I'm thinking probably like the left atrium.
It is. That's exactly right. So remember, this is left atrium.
Okay.
Here's another chamber that's closest to the anterior or to the sternum. What chamber is
That's
this?
the right
What?
right ventricle.
Right ventricle. Excellent. So that's what's so important is you got to know that the left atrium is closest to the spine and right ventricle is closest to the sternum. Just memorize that. Don't try and figure it out. Just memorize that. And then you can figure out everything else. Left ventricle's over here, and then what's left over here?
Right atrium.
Good. And then what's this in dead center?
Ascending aorta.
Good. It's the aortic root. Excellent. Very good. All right, good. All right. So now we go next. Now these are coronal views here. I'm not going to torture you too much with that. This is liver. We have the heart here, and this is more of an anterior view. So the most anterior chamber we have is right ventricle. Then we come back here. This is left ventricle, and here's the aorta, aortic alpha. So remember that dead center aorta sits right there. Okay.
Okay.
Okay. Excellent. And these are some more further views. I'm not going to torture you all too much more with anatomy at this point, because I think I've tortured you enough. Okay. All right. Who's next?
How about Andrew?
All right, Andrew. All right. What's going on? We have 2 patients here. Okay. So this patient that I'm pointing to right over here is a frontal chest radiograph. This one over here is a frontal chest radiograph. In fact, first I'm going to ask you, can you hear me, Andrew?
Yes, I'm here.
Okay. So Andrew, what's going on here? This is kind of a incidental finding.
Looks like dilated cardiomyopathy. Or are you just pointing up top there?
Just pointing out here. What am I pointing to here? This so bright.
Something in the trachea.
Very good guess, but it's not the trachea. It's something else.
Is it a feeding tube?
What other tube? Well, okay, you're on the right track. So it's the esophagus, and someone is drinking contrast. So, so what's the difference between this chest film and this? And you see the heading, pulmonary vascularity. Okay, one of these has increased vascularity, and one has decreased. So which one of these two has? In fact, this one right here, does this have increased or decreased vascularity?
Increased.
Okay. And why do you say that?
You can just kind of like follow some of the vasculature all the way out into the parenchyma of the lung.
Okay. So that's interesting that you would say that, because I agree with you. However, they're talking about way out here, way out in the periphery. And some people, supposedly this is a little truncated. This one person's got some pulmonary artery hypertension. So maybe not the best example, but this over here, can you see the vessels very well?
Yeah, you can pretty much follow them all the way to the outside.
Yeah, you can follow them all the way out, and there's what we call interstitial edema. So this is actually supposed to be increased vascularity. This is decreased. I'm going to show you some better examples later. So that's pulmonary vascularity, okay? And so this one right here, is this increased or decreased pulmonary vascularity?
It looks decreased. It looks like they kind of stop before they get to the rib cage.
Well, look at the lungs. You see how lucid these lungs are? You can see really well. And you can't see the lungs as well over here. So we come back here, and actually you can see vessels coming out here, here. The lungs look kind of hazy. So I apologize, I don't have a better example. Actually, I'll show you one. I'll show you CT where you'll get the whole idea of increased pulmonary vascularity, which is right here. And I know you don't look at a bunch of CTs, but all this honeycomb appearance, that's usually completely normal, and it's all filled in with interstitial edema. And what is this over here? Any idea?
Could be pleural effusion.
Perfect. Very good. So if you've got overcirculation, pleural effusion, older patient, they're not breathing well, number one diagnosis. So you're doing rounds in intensive care. Someone's in the cardiac unit, and they're not breathing well. They got a Foley catheter in. They're on Lasix. Most common diagnosis in an older patient with cardiac problems?
Heart failure.
Heart failure, exactly. And that's what this is. Very good. So remember that, heart failure. You're going to hear it again. Okay. All right. And Andrew, you're off the hook. Thank you much. This is just a case of cardiomegaly. Aaron, who's next?
On.
Okay, on. So what's going on here?
You said that he had, this patient has cardiomegaly.
Yep. Do you agree with that?
Yes, because the diameter of the heart, or like the heart shadow, is more than, I guess, of like half of the AP diameter.
Yep, or the transverse dimension. Yeah, good. So it's big heart. And what is this structure here? It's curving off.
Is that the aorta?
Yes, descending aorta. Very good. And what are all these wires and clips? What's going on here?
Looks like he has a cabbage, maybe.
Good. And I'm sure most of you may know that's bypass graft surgery. So most likely cabbage, but it could be heart valve, but they've had heart surgery of some sort. And judging by the clips and all, most likely is a cabbage. And they did some vein harvesting. So good. Excellent. All right.
If you don't mind, I have a question from that last
Yes.
slide there.
Yeah.
When I initially saw this, I was actually thinking tetralogy of Fallot because it looked boot-shaped to me. How would
Right.
you differentiate those two?
Well, I'm going to show you a case of tetralogy of Fallot. And I think you're pretty much, after I show you some of these cases, you're going to realize, even if you see a classic case, there's so much overlap.
Gotcha.
And a tetralogy of Fallot is going to be a younger patient. You're going to be cyanotic. And what you'll do is you'll end up doing an MR or an echo to make the diagnosis.
Okay.
And then you go back and look at it. Oh yeah, it's boot shaped and it's got this overriding aorta, et cetera, et cetera. But
Gotcha.
yeah. So
Thank you.
yeah. Okay. All right. An did a great job. Who is next?
Daniel.
Daniel. All right, Daniel. 2 studies here. What kind of studies are they? Got this one here. This one over here. What's this one?
CT.
Good. CT of what?
The thorax.
Good.
Heart.
Thorax. And what's this structure here?
That'd be the heart.
Good. Pretty simple, straightforward. What's this back here?
That's not.
So it lights
Aorta.
up. Aorta. Descending aorta. Very good. Okay. What kind of study is this over here?
MRI.
It is an MRI. Good. Good. We'll just leave it at that. Now, what this is, these two are showing the same thing. This structure right here, which chamber is this right back here next to the spine?
Left atrium.
Left atrium. So this is left atrium here. So what chamber is this one over here that's off to the left?
Left ventricle.
Left ventricle. Okay. I know you've hundreds, if not thousands of these. So what is unusual about this left ventricle or these left ventricles?
Is the septum too big?
It's too big. There's a septum. Good.
Taking it.
Exactly right. So what kind of diagnosis is that?
The hypertrophic cardiomyopathy.
Yeah, that's exactly. All right. That's a case of that. And then this, what kind of study is this?
CT.
Good. What's the structure here?
Heart.
What chamber is this?
Left atrium.
This one?
Left ventricle.
Good. And this one?
Right atrium.
Right next to the
Or right
structure.
ventricle.
Right ventricle. Now, this is, like I said, I know you've seen hundreds, if not thousands of these. What is going on? What's unusual about this, the left ventricle and right atrium, or left ventricle and right ventricle? What's unusual about them?
They're too big.
They're way too big. Very thin walls. This is kind of like a baggie. We call it a baggie heart. And this is the same person. And they have problems with very poor ejection fractions and heart failure. And this person, you probably can't tell, but the humerus is unfused. This person's probably 9 or 10 years old. So it's not a good thing to have, certainly at that age. And what do you think? What's the most common cause for a dilated cardiomyopathy?
Yeah, I thought it was usually idiopathic.
It's idiopathic, but the thought is usually caused by some virus. But it's not congenital. It's either some viral / idiopathic. So good. All right.
Question
Excellent.
for you, Dr. Vanderberg. Someone in the chat asked, in the MRI in the previous image, can you see the
Yep.
septum and where would that be?
Septum's actually right here. That's septum. The left ventricular wall, and it separates the left ventricle from right ventricle. So right ventricle's here, left ventricle's here. And with the ventricular hypertrophy, most of the time it's the whole ventricle that hypertrophies, but sometimes you just get septal hypertrophy, but this is it right here. And this is it over on CT.
Thank you.
Okay, who's next?
Danielle.
Danielle.
Hi.
Danielle, what do you think about this? What do you think about the heart size on here?
It's large.
It's large. It's very good. Good. And what in the world's going on over here? It's beautiful psychedelic imaging.
It looks like we might be looking at blood perfusion of different sections of the heart.
Good. And what kind of study? What kind of equipment are we using?
Oh, that's a great question.
Yeah.
I do not know the answer to it.
Okay. Does this look like a CT?
On the left, it's an X-ray. The thing on the right, I'm not sure what this is.
Okay. So this
might
is. Go ahead.
No, I'm sorry. Please, you go ahead.
This is a nuclear medicine scan.
Okay.
Okay, it's called SPECT imaging, which we inject radioactive dye into the patient, and it gets collected into this structure. And this structure that's lighting up is part of the heart. Any idea which part of the heart would light up like this?
If the top is a different plane than the bottom, so
It is.
one.
It's
Okay.
the same structure, but what we do is we do axial slices on top.
Okay.
It's short axis, and this is what we call a long axis.
Okay. It's shaped like a ventricle.
Good, excellent. Which one?
Based on the thickness, I'm going to go with left.
Perfect. Very, very good. So this is left ventricle, and this is the one we care about because that does all the work. And this is a perfusion scan. And we can do this with and without stress, looking for ischemia. If there's an infarct, we'll see a little hole in here. Now, this is the reason I show this one, that this heart chamber here should be less than the thickness of the wall. And this is definitely a little big. So this patient who's got cardiomegaly has a big heart on a perfusion scan. And you could argue that this is a dilated cardiomyopathy, certainly not the one like we saw before. But this happens a lot in the older patients. They just have their heart starts failing for whatever reasons, whether they have a bunch of microinfarcts or whatever, and they start getting a little bit of a dilated cardiomyopathy, and their ejection fraction just goes down. Okay. Let's see. Very good. All right. Okay, we're going to change gears a little bit here. Who is next?
How about Grace?
Okay, Grace.
Hello.
Hello, how you doing?
Good. How are you?
Good. So what do you think is going on here? What kind of study is this?
An X-ray.
Okay, is it frontal or lateral?
Frontal.
Good. Of what?
The chest.
Okay, you're batting 1,000. Excellent. What are these little things here? That and this and this.
Are those like EKG markers?
You would think so. And I think that's a very excellent guess. These are actually snaps on a gown.
Oh.
Which is kind of silly, but I see so many of them, and it's kind of bad form to take an X-ray with them. But anyway, that's what that is. But there are some EKG lead little snaps that can look exactly like that. So I think you're spot on with that answer as well. Okay, so does the heart look big or small or normal?
It looks like it extends really far to the left side of the chest wall. So maybe a little big?
Yeah, maybe borderline. I'll give you that, borderline. What's the structure here?
Is that the aorta?
Yep. And what is this?
Is that the descending aorta?
So descending aorta is here.
Okay.
So I don't know if you ever heard of these people talk about moguls. I don't know if you all ski or not. You talk about the moguls of the heart. But first one is the aortic arch. The next one is this structure here. The next one is a left atrium or left atrial appendage, and then left ventricle. So this one right here, I'm going to tell you, is way too big, and it's connected to this structure here. You know what this is over here?
Is that a pulmonary artery?
Yes, yes, very good. Right pulmonary artery.
Okay.
So this right here is the main pulmonary artery. It comes out here from the right ventricle, comes up here, and normally it just makes a little bump here. This is huge. So if you have a huge main pulmonary artery, what diagnosis are you concerned about?
Pulmonary arterial hypertension?
Perfect. Very good. Excellent. Very good. All right. Good. Yeah, we're going to skip that one. Well, no, we should. No, I really shouldn't. Okay, who's next?
Jesse.
All right, Jesse. This is one of those. Well, let's just take a look at it, and we'll figure out what's going on. So I'm telling you right here that there's pulmonary overcirculation. Do you agree with that? Disagree? Or kind of hard to tell? What do you think?
I think I'd agree. It looks hypervascular.
You can see vessels out here, but more importantly, these vessels centrally look big. Okay, they're just a little too big. All right. So, what kind of heart defect gives you overcirculation? Is it a left to right shunt or a right to left shunt?
Left to right.
It is, and I know you're very confident of that answer, but that's okay. But that's exactly right. It's a left to right. So people with left to right shunts, are they cyanotic or acyanotic?
Acyanotic.
They're acyanotic. Very good. And what are some of the common heart defects that give you a left to right shunt?
PDA.
Okay, what's more common than that?
ASD.
Yeah, ASD is the most common of those, and then VSD. So this person has an ASD. So that's overcirculation. Okay. All right, and who is next?
Justin.
Justin. All right, Justin. What kind of film are you looking at, and what findings do you see?
We're looking at an X-ray, and it looks like the heart looks like a balloon to me.
Yeah,
so,
it looks big, doesn't it?
Yeah.
Good. So if you look, the central pulmonary vessels are decreased. So is this a left to right or right to left? And I'll tell you, the first question you're going to ask in the history is what?
Age of the patient.
Okay, you ask the age, and I'll say it's 21.
Okay.
What's the next thing? If you're worried about a heart defect, what's the next question you're going to ask? History-wise.
When did it start? What were you doing?
It started at birth.
Oh.
So remember the difference between left to right and right to left shunts. Clinically, what's the difference?
Cyanosis.
Exactly. So you're going to say, is a patient cyanotic or acyanotic? Okay.
Okay.
And how do you diagnose cyanosis?
You'll be looking at discoloration of the lips and some of the extremities.
How about a pulse oximeter? Would that give you some information?
That would, yeah.
Yeah. But like you said, you look at their lips, see if they're blue. Also, the respiratory rate's going to be up. So good. And I think this ended up being Epstein's, but it's actually immaterial because the point is you want to look at decreased pulmonary circulation and we realize that it's cyanotic. Okay. Yeah, so it's an Epstein's. And I'm not going to go, and I don't know if on your quizzes you're going to be asked, or your tests you're going to be asked specifically. And if you are, you might just want to memorize just a couple of these congenital anomalies, but don't go crazy trying to learn them all because it's very, very confusing. But with Epstein's, you get this overriding large right atrium, tricuspid valve is defective. You have to have an ASD, otherwise the patient's not going to survive. In fact, almost all of these right to left shunts have some type of VSD or ASD to have mixed circulation. So anyway, that was an Epstein's. And I do not expect anyone to say, look at this, go, oh, that's obviously Epstein's anomaly. Because you'll see another one. We look at one that called the egg on a string. It looks just like this in this transposition of the great vessels. And to me, they look exactly the same.
You kind of just answered this question with what you said there, but Shaviante had a question.
Yes.
Looking at the X-ray itself, how can you know whether or not it's cyanotic, or would you have to get that from the
You really can't. You can guess. I mean, I could look at this and say, okay, the pulmonary vessels essentially are kind of decreased. Person's on a cardiac ward. They're young. I'd be like, okay, it's probably cyanotic. But no, you can't tell just by looking at the chest film.
Gotcha. Thank you.
Okay. And Aaron, this is for you.
Oh, there we go. Okay. Yes.
All right. So the only thing that you can tell about this that's a little unusual. So boot-shaped heart. Yeah, Yeah, this is a classic case of this. But what on this chest film is kind of unusual that you don't see on a normal film, on a normal person?
The main thing would be the boot-shaped heart. The diaphragm looks a little bit flat to me and looks a little bit overexposed.
Okay, that's okay. So the heart shape is kind of funny. But what about the aorta? Where's the aorta?
Yeah, it's over on the right side of the patient.
Exactly, yeah. So this person's got a right side aorta. So, and a lot of people, and this is a tetralogy of flow. I'm pretty sure you're going to be answering questions about tetralogy of flow. So know the 4 components of a tetralogy of flow. Know that it's boot-shaped. And just be familiar with it because you will be asked. I'm pretty sure you'll be asked. That's pretty fair game on a test. Okay.
All right.
So, and here are the 4 components: overriding aorta, pulmonary valve stenosis. You have to have that septal defect and RV hypertrophy. Okay. Here's a healthy heart. Here's a tetralogy of flow heart. See the pulmonary valve stenosis there. Okay, excellent. Okay, the most common abnormal heart finding is this, and who are we going to torture with this?
Kate is next.
Kate, all right, Kate. Let's see. Her mic looks like it's
I'm
off.
there. Sorry.
Yeah. What do you think, Kate?
What's the question? I'm sorry. Wait, let me put my earphones. There's a lot of noise here. Hello?
Yeah, the question is, what is the most common abnormal heart finding? And this shows it. It's nothing real. It's nothing subtle. It's obvious, and we've been discussing this.
You mean like the coronary artery disease?
No, but when you look at a chest film,
Mm-hmm.
what's the most common abnormality that you'll see on a chest film if someone has something wrong with their heart?
The enlarged heart or the disease?
Enlarged heart. Perfect. That's exactly what I wanted you to say. Cardiomegaly. Okay. Now, say cardiomegaly. Can you tell what kind of disease they have based on this chest film?
Sorry, I can't.
No, of course you can. Well, if you would, then we wouldn't need CTs and we wouldn't need echoes and MRIs. You're right. So just based on this, you cannot tell what kind of heart disease someone has just because they have cardiomegaly. Because they have cardiomegaly, it could be a dilated cardiomyopathy. It could be a hypertrophic cardiomyopathy. It could be multiple infarcts. So it could be congenital heart disease. So we just don't know.
Yeah.
Okay. And this again is another rehash. So what's going on here with this vessel and this vessel? These look big or small?
They look big to me, though.
Yeah, this is big. So this is increased pulmonary vascularity. You can actually see the branches coming out there. Now, we really didn't talk about this too much, but one of the most common cause for increased pulmonary circulation is a patient who has to breathe a lot to get air into their lungs, and they kind of overwork their lungs, and when they overwork their lungs, they increase the negative pressure, and the pulmonary arteries get bigger. So what kind of patients do you know that have to breathe fast or breathe a lot?
Fast. People with some kind of.
What's that?
No, I'm thinking when you say fast, breathing fast, like hyperventilating, people with some kind of lack in. What's the hypoxic?
Yeah, exactly. They're hypoxic. So what kind of patients are hypoxic? Very, very common. Very common. You've got probably friends and relatives.
People with you mean like people with obstructive diseases?
Exactly. COPD. Very good. Very good. Excellent. Okay. So that's the most common cause for that. So very good. All right, Kate. Thank you.
Thank you.
All right. Who's next?
Nick.
All right, Nick. So I even tell you, I have it in quotes what this is. And you look at this, to me, this looks like that Epstein's case we just looked at, but it's not Epstein's. This is a newborn. And what is the first question you're going to ask, clinical question you're going to ask about this patient?
I would guess if they're cyanotic or not.
Good. And they are cyanotic.
So that means they have a right to left shunt?
Right. Correct. Okay. Does this look like tetralogy of flow?
No.
No. Now, could it be? It could be. Does this look like Epstein's anomaly that we saw earlier?
Yeah, a little bit, yeah.
It does, but it's apparently not. So is there any way that you can tell what this is just based on the chest x-ray?
I don't think so.
No. Now, even though it says egg on side, and when you say egg on side, it means it's this diagnosis. So what kind of study could you do to figure out what's going
on? An echo?
You can do an echo? Yeah. And what else?
A CT scan?
You do a CT or an MRI. Yep, very good. And this turns out to be a transposition where there's a flip of the aorta and pulmonary artery. So normally, pulmonary artery comes off of this chamber right here, which is the right ventricle, and it comes off the left ventricle, and the aorta, and they get switched. So normally, if it's a perfect transposition with no ASD or VSD, the patients are totally cyanotic and they can't live. But anyway, so this is a transposition of great vessels. Okay. All right, we're almost through this. Okay. Who is next?
Robert.
Okay, Robert.
Okay, I'm here.
All right, Robert. So it says rib notching. You don't even have to look at this chest x-ray. There's one classic diagnosis that goes along with rib notching. And And the way the rib notching occurs is that you get these hypertrophied internal thoracic vessels that hypertrophy because something's blocked, and they get big and they notch these ribs. But this is a congenital heart disease that is not super common, but you'll probably see a case. And it really has more to do with the aorta than it does with the heart itself. So what kind of congenital heart disease do you know that can affect the aorta and give you rib notching? And if you look at the slides, you just go to the next one, it'll tell you the answer.
I don't know.
Okay, it is coarc.
Coarctation.
Have you ever heard of coarc?
Yes, I have.
Okay, and someone, oh, that's great. Someone just said, can you point out the rib notching? Actually, that's a very good question because I can't, but I'll tell you where it is. It's right there, right here, right here, right here, right here. There's a notch there, notch there. It comes right along here on the posterior ribs. So this is not a great case of coarc, but I stole it from the internet and they claimed it was. So what's interesting is that you don't see a good aortic knob here, and that can definitely go on with coarc. It depends whether it's preductal or postductal. So anyway, coarctation, it's important that you know about it. Do you think it's cyanotic or acyanotic?
It is cyanotic.
Why do you say cyanotic?
Because you're not going to have enough blood getting to the extremities because of the coarctation.
That's a good thought, but when you say cyanotic versus acyanotic, what you're talking about, does the pulmonary artery pump out oxygenated blood?
The pulmonary artery is going to be pumping deoxygenated blood.
Say what?
The pulmonary artery is pumping deoxygenated blood.
Why is that?
Because it comes out of the right heart.
Yeah, and the right heart. So the heart is perfectly fine. It's working just fine. And the heart and the lungs are working fine because it's oxygenating. So in coarc, oxygenation is fine. The problem is that you get obstruction down the pike. So this actually is an acyanotic heart defect because the heart itself is working fine and it's getting the right ventricle is getting oxygenated blood. Was that confusing or?
No, I think that makes sense.
Okay.
On the last slide, can you actually see the coarctation in that, or are you just telling because of the signs around it?
Yeah. Okay. To be honest with you, what I should have done is shown a CT or an MRI because it's really obvious. It comes out. It comes. The aorta has got this beautiful arch, and there's a real a stenosis in it. And so next time when I put this slide together, I'm going to add a CT or a MRI. Okay. Very good. All right. Let's see.
I just had a quick question.
Yes.
In terms of the rib notching, is it more profound in the postductal coarctation?
Yes.
Does it not matter?
Yes, it is. That's correct. In fact, it's been a while since I reviewed this. Preductal it's infantile because you got to discover it early and take care of it early, and they don't get old enough to get the rib notching. So the adults get old enough, and that way you can see the rib notching. Now, having talked all about the rib notching, how often are you going to see it in real life? I can tell you, not often. But let's see. Aaron said he's got some cases somewhere.
Yeah, I just wanted to share that with everyone there. If you want to see some with the contrast or whatnot, so you can see the coarctation a little bit better, then that link I sent you there will show you a number of different cases with different imaging modalities and whatnot.
Okay, now I'm going to go back here and let's see. Karen. Kidney. And go here. All right, how's everybody doing? Oh my gosh, we're almost. So are you having a test on kidney, lung, and heart, or mainly heart, or?
That's correct. No, it goes over all of what we have. So we have heart, lung, and kidney.
All right, well, let's get rolling here because these are some real good stuff here.
Excellent.
Okay, so we're going to switch gears. Going to go to kidney and lung cases. So whenever I ask anybody, this is probably one of the most important slides I will ever show you in anything in radiology. And that is, what if I ask you what is the differential diagnosis of anything, whether it's a tumor, infection, whatever, you say, if I show you a nodule, if I show you a mass, if I show you an infiltrate, and I say, hey, Dr. Smith, what do you think about this? Well, it could be a tumor, it could be infection, it could be trauma, or maybe it's something else. Remember this mnemonic. This will save you in so many cases, okay? This is going to come up again. So remember it. All right. So first we're going to talk about kidneys. We have benign malignant masses. We'll cover infection, trauma, and other diseases. Okay. Who's next?
Cheviante.
Okay, Cheviante, you there?
Yes, I'm here.
Okay. All right. What is going on here? What kind of study is this?
CT scan?
Good. CT. All right. And this is an axial, which means we cut in an axial plane. So what is this structure here?
The kidney.
Good. What's this over here?
The liver.
Good. Very good. What's the structure over here?
Is that the left kidney?
Very good. Very good. You're on a roll, so I'm gonna keep. What's this?
Is that the descending aorta?
Excellent. Excellent. Very good. I'll just let you know this is probably superior mesenteric artery. Kind of hard to tell because it's kind of a little low. This structure here that has some air and debris in it, and maybe some food.
The stomach.
Good. And what's this right here?
Is that the pancreas?
Pancreas is right here.
Oh, what about the
Out
spleen?
here. Spleen. Very good. Excellent. Okay. All right. So this is the kidney that has this big structure in it. What is that?
A mass?
It is a mass. Now, a mass can be solid or it can be a cyst. Okay? How do we determine whether something is a solid or a cyst?
Maybe the color?
Okay, well, in this case, we look at what we call Hounslow units. So we can actually measure the density here. Okay? We look at how, is this pretty sharply marginated or is it like really irregular? Like right here.
Looks
Can you see the border pretty well there?
What is that?
Can you see the border really well?
I can see it. Yes.
Yeah. So you got this mess. Okay. So the question, the answer is, then what we can do is we can do an ultrasound, okay? So we do an ultrasound and we get this. So does the border look pretty sharp?
Yes.
Does it look pretty dark in here? Like you don't see a bunch of, yeah. And back here, does it look brighter or darker?
Brighter.
Brighter. Okay, so that's the classic definition of a cyst. This is a cyst. This is the most common kidney lesion, okay?
Okay.
The most common. Many people have kidney cysts. They're benign. You don't touch them, you leave them alone, okay?
Okay.
So, very good. Now, there are diseases that have multiple cysts in the kidneys. Do you know of any diseases that have multiple cysts in the kidneys?
The autosomal dominant kidney, polycystic kidney
disease.
Very good. Okay, how about the autosomal recessive? Does that have cyst as well?
Yes.
Yes, it does. Any other diseases that have kidney cysts?
I think the medullary one can have cysts, but it doesn't always.
Yeah, not so much, but so there's multicystic dysplastic kidney. I don't know if you've heard of that. MCDK, that occurs at birth. There's some phacomatoses that we'll cover, that like von Hippel-Lindau. Have you heard of any of those? Have you studied any of those?
Yes.
Okay. Well, you know, it's interesting. I remember being in your shoes and studying about all these diseases I've never heard of. And I studied for the test and I quickly forgot all about them. And then I did my radiology residency and I had to learn them all over again. But I actually learned them so I can remember a little bit more than I did after my first year of med school. But so you're getting a lot of information. So that's excellent. Very good. Okay, who's next?
William.
William.
Yes, sir.
All right, William. What kind of study is this, and what's the findings?
Well, it appears to be a CT without contrast, maybe.
Okay, it's kind of difficult to tell. There's actually some oral contrast here, but
okay.
IV contrast. I think you're probably right. I think you're right because normally these. Well, what's going on here?
Well, appears to be a lot of mass.
Okay.
There's not very many discernible organs.
Okay. Well, maybe what's this here?
I mean, it's the liver.
It's the liver. Good, liver. So it's got a bunch of these little masses in it.
Yeah.
What is this structure here?
I mean, a giant kidney.
Good. It is a giant kidney. There's another giant kidney over here. So you got two giant kidneys and a liver, and they all have these multiple. And I'm going to tell you, these are cysts. Okay.
Mm-hmm.
These are cysts. So you got big kidneys, lots of cysts in the liver. What's your diagnosis? And you know, your classmate Xaviante was just talking about this. So
it's hereditary polycystic
kidney disease. Very good. Is this the dominant or recessive version?
Dominant.
It is. Now, why do you say that?
50-50 guess.
So which one occurs in kids and infants and which one occurs in adults?
I'd say kids would be heterozygous or homozygotes, maybe.
Well, they're recessive. It's autosomal recessive.
Right.
So they have to be homozygous, yeah. But you also have to understand that the autosomal recessive and autosomal dominant diseases are actually different. They're not the same disease.
Okay.
So remember that they're not the same disease. But to get the infantile, you have to be homozygous for it. To get the adult, you just have to have one of the chromosomes.
Okay.
So this is adult polycystic kidney disease. What kind of problems these people have? It's pretty easy. It's pretty straightforward.
Yeah, I mean, you're gonna have issues with the kidney and the liver, so you'd have probably some. Depending on, I don't know how functional the liver is because we haven't done that, but you're gonna have low GFR, probably maybe some hypertension.
If hypertension and they get kidney disease. Yeah, the kidneys fail. Their liver, surprisingly, is pretty resilient. You don't need much liver to work, but so their biggest problems are hypertension and kidney disease. So very good, excellent. All right, and ultrasound, you see a bunch of cysts. So that's what that is. So to summarize, renal cysts, they're benign. You use CT, MRI, ultrasound. Ultrasound, three criteria you have to have. It has to be anechoic, which means no echoes. It has to be sharply marginated, and has to have that enhanced posterior transmission. So to show that again. Sharply marginated, anechoic means no echoes, posterior enhanced transmission. Okay? All right. There is a classification, Bosniak classification. Has that come up? I'm booting this back to Aaron. Has that come up in your studies at all, Bosniak classification?
I don't specifically recall it, no.
Okay. Okay. Then I'm not going to spend any time on it, but I'm going to let you know that sometimes, often in my line of work, I see a cyst, and I have to decide whether it's benign or not. And so someone came up with this classification. If it's completely sharply marginated, anechoic, there's no septations at all, then it's a type 1, it's malignant. If it has a septation or some microcalcification, it's a type 2, but still not malignant. Then you start getting into the gray area. As soon as you get a mural, little thickness nodule, or you get multi-septations, like particularly here, then you start worrying about being malignant. And if you have a lot of wall thickening to septa and mural nodules, then it's malignant. Don't spend any time on it. Just know there is a classification to look at cysts, whether they're benign or malignant. Okay?
Okay, we're going to switch gears. Question here too. Yes. She was asking if you can tell by looking at the CT or whatnot if it's an adult or a child.
Well, I can, if I looked at more images, well, it's a very good question. The first thing that I look at when I look at a CT or any study is I look at the name, the date, the demographics, and the history. And I always look at age. So yes, I can, because I actually look at the age. Now, would I expect someone like you to know that this is an adult? No, I've looked at thousands of CTs. I can tell you this is an adult just by looking at the vertebrae, the size of the liver, and also knowing the disease. But no, the first thing you do is always look at the name and history and so forth.
Thank you.
Okay, who's next?
We're going back to Ahmed.
All right, Ahmed. Okay, Ahmed. What kind of study is this?
CT without contrast?
This is a kidney. Does it look bright or dark?
I guess bright. It kind of blends in.
Yeah, but it's brighter than all this here. I know you haven't seen many kidneys, but this is bright. So it's with contrast, IV contrast. Speaking of which, what do we give for contrast in a CT or an X-ray?
A dye.
Well, yeah, that's right. What kind of dye? What's in it? What element is in there that gives us the bright color, the brightness?
Something radiological. I don't know.
It's radio dense, but what element? Well, it's an element on a periodic table. Your thyroid gland likes to concentrate.
Iodine?
Iodine. Yep, exactly. So we give iodine as an IV contrast. And I'm not going to go into all the physics of it, but it has a property in the range of the X-rays that we use that makes it very dense. Okay? So
Yes,
and you can give IV iodine, you can give it orally, rectally. But this is IV contrast. Okay, so what's the finding?
So I see the right kidney is larger than the left kidney.
Yep. Okay. And what's this right here?
Looks like a tumor on top of the kidney, maybe?
Good. It's a mass. We say on top, it's actually part of the kidney. Okay. You know, it's infiltrated the kidney. So it's coming. So it's a mass of the kidney. So this is going to test you to see. Remember that one first slide I told you, the most important slide that I'm going to show you? What's the differential diagnosis of this mass?
So it's either a tumor infection It's not trauma or other.
Why couldn't it be trauma?
Will trauma cause a mass to grow?
Absolutely, it can cause a hematoma.
Oh yeah, that's true. Yes, sir. So it could be all of those.
Yeah, so it could be all of those. So it could be a tumor, it could be infection, it could be trauma. So I will tell you, this patient's 65 years old, painless hematuria.
Thinking tumor, cancer.
Yeah, cancer, tumor. All right, very good. And what kind of cancer?
The most common is the renal cell, small cell carcinoma.
Yeah, renal cell carcinoma. Okay.
Yes, sir.
Okay, and this is actually the same patient, but you can have big, huge exit. Here's the kidney, bright echoes. This is renal sinus fat, and there's this big mass. So that's a tumor till kidney tumor till proven otherwise. Okay, now, Ahmed, since you're doing so well, the abnormal side is which? The left side or the right?
The left side is the abnormal.
Good. Is this with contrast or without contrast?
With contrast.
Good, because it's bright. What is going on here?
A blockage maybe, because you can see a little bit of the renal artery too. Or
Yeah, so you got tumor that's growing into here. Actually, it's into the renal vein. Okay, and if you learn about renal cell carcinoma, it's one of the tumors that likes to invade into the vein and actually go up into this structure right here, which is the IVC.
Inferior vena cava. Yes, sir.
Yeah, so it can actually go into there. So this is one of the properties of renal cells. It likes to grow inside a vessel. Okay. All right. So excellent job, Ahmed. So anyway, renal cell carcinoma, there's different types here that you'll probably get tested on. From a clinical perspective, the tumor size is most important. And the peak years are 60 to 70. So I think just about all of you are out of that age range. There are some underlying congenital diseases. Von Hippel-Lindau, this is tuberous sclerosis. And Bert Hogg-Dubie, I've never heard of, but I got off the internet, so it must be true. Venous tumor thrombus is very common. I've seen several cases of this for certain. Renal cell is not the best cancer to get. You have metastatic disease in 25%, and it goes to these places here. There are some risk factors for renal cell carcinoma that I didn't put up here. Basically, obesity, alcohol, obesity, alcohol, and smoking. And then there are some congenital things as well. So, all right, anybody, any questions about renal cell carcinoma? Okay. All right, who's next?
Alex.
Okay, Alex. All right. So we got two studies here. What's the difference between the two? The same patient. What's the difference between the two sides? One's got an arrow, one doesn't. But why does his kidney look this way here and look this way here?
With and without contrast.
Yeah. So is this with or without contrast?
That's without.
Good. And here?
With contrast.
What kind of contrast do we give?
Iodine.
Excellent. All right. And so what's this little arrow to?
Some sort of possibly a cyst popping out, some sort of mass that's coming out.
Very good. So it's a mass. Now, so see this dark area here? See this dark?
Yeah.
What is that?
That's like the retroperitoneal fat.
It's fat.
Fascia.
It's all fat. Very good. It's fat. When you have really dark, it's that is fat, and fat is good. In spite of what you'll see on the internet and social media, fat is good. And so this tumor or this mass, does it enhance like the rest of the kidney or not?
No.
No. So I mean, on the outside it does, but on the inside it's kind of dark. So I will tell you that we can measure this, and when we measure it, we find areas of fat in this tumor. So a fatty tumor in the kidney is what?
Angiomyolipoma.
It is it's an AML. Very good. And are those benign or malignant?
Those are benign.
Benign. So do we do anything with them?
You want to surgically resect them because they have possibility of like hemorrhage.
Okay, the second part of that is absolutely correct. The first part, we do not resect them. We leave them alone. You'll see, I see lots and lots of AMLs. Now, if you saw a really huge one, maybe, but I see a lot of them and we leave them alone. We don't operate on them. Okay, so it's the most common solid renal tumor. They contain fat. They can be associated with neurofibromatosis, tuberous sclerosis, that's Sturge-Weber, von Hippel-Lindau. Most commonly, tuberous sclerosis. The large ones bleed. Here's a case of tuberous sclerosis that has, see all these multiple little fat things? If you try to resect those, you basically take out the whole kidney, so you don't want to do that. It does not affect kidney function. They're benign. However, one of the problems that you get is this, which is what? Andrew? What's going on here? What kind of study is this?
It's a CT.
Hey, with or without contrast?
With contrast.
Good, good. And what in the world is going on?
It's either a tumor, an infection, trauma, or something else.
Good, good. Well, this happens to be two of those. Got this big mass here. See this density here? Is that low or high?
That is low.
Good, low. Good. And I'll tell you, this is fat, okay? And see the little thought-provoking arrows there? That's bright. What's going on there?
I do not know.
Okay, that actually is a blood vessel and active bleeding. So that's active bleeding. So this is an AML that has hemorrhaged out. And so most of this, the soft tissue is all blood. So this is one of your AMLs that decided to bleed. This is not very common. I have never seen a case of this, but it does happen. Very good. Okay, very good. Andrew, who's next?
On.
Hi.
Okay. All right. On, are you there?
Yes.
Okay, what's going on here?
Looks like the left kidney is a little irregular.
Good. Is this with or without contrast?
This is with contrast.
Good. And okay, so there's a mass here. Does it look pretty well circumscribed, or does it look really irregular?
I can see the border, so I would say that's circumscribed.
Good, good. Does it enhance as much as the kidney?
No.
Okay, and this little dark area here is central scar. Okay, what's the structure here?
You say it's a aorta?
Good. And what's this right here?
Is it blood?
That's calcification.
Oh, okay.
This is atherosclerotic disease. Okay, and what's the structure here?
Is that the liver?
Good. So there's another finding that this patient has, I haven't pointed to yet, that's very common. And I could open up to anybody. It's not, it's either you see it or you don't. What is this? What's the structure here?
Is it part of the liver?
It's right next to the liver.
Are we looking at gallstones?
That's gallstone. This is a gallbladder, and that's a gallstone. Yeah. So Anyway, that's an aside. Anyway, on back to you. So you see this mass in this kidney. What do you think of it? What's the possibilities?
Well, it could be a tumor, infection, trauma, or something else.
Good. And of those, what do you think it might be?
You said it's a scar, so it could be infection.
Okay, it could be. I mean, how are you going to figure out what this is?
You take a biopsy.
Okay, you could take a biopsy. What else can you do? Could it be a complex cyst?
Could do an echo. Oh, not an echo, an ultrasound.
Yeah, so we do an ultrasound. Good, and it turns out to be a solid mass. So if it's a solid mass in a kidney, do we have to biopsy it?
I guess yes.
Yeah, so it's interesting. It used to be that if we saw any solid mass in the kidney, we just take the whole kidney out. Nowadays, we do kidney sparing surgeries. And so this could be a renal cell, could be an oncocytoma, which is a benign tumor, some other mesenchymal tumor, it could be metastatic disease, all the above. We just can't tell. This turned out to be an oncocytoma. Cannot differentiate from renal cell. Older males. You can have central scar, but that's not specific. So basically, you cut it out, and it turns out it's benign, and you feel good about it. Okay? Okay, who's next?
Daniel.
Daniel. All right, Daniel. What kind of study we got here?
CT.
Good. What plane of imaging are we doing? Is it axial, sagittal, or coronal?
Coronal.
It is coronal. We won't go over that right now because it's kind of hard to explain it, but you're right, it's coronal, so we're going a slice that's kind of up and down. Okay, so we got this spot here that doesn't light up really well. And this is a delayed image. This is an immediate, so we give contrast, we do a scan immediately, and then we wait until the contrast gets into the collecting system. And we still see this here. So it is a mass. They call it bean-shaped. Whatever. It's interesting how it's more infiltrative, like you don't get this big mass, it just infiltrates there. And it grows here into the collecting system. In fact, it actually comes from the collecting system. So renal cell is the most common kidney tumor, primary kidney tumor. What's the next most common one?
An oncocytoma?
No, that's actually not that common. So a renal cell carcinoma is what type of tissue type is it?
It's PCT, I thought. The proximal tubule.
Say again?
Proximal tubule cells?
Yeah, but what tissue type is it? Squamous cell, adeno, cuboid?
Oh, squamous.
It's adenocarcinoma. Renal cell. But there's another tissue type that's in the kidney, that's in the collecting system. What kind of histologic tissue cells do we have in the collecting system, the ureters, and bladder? Transitional. Beautiful. Transitional. So that's what this is. This is a transitional cell carcinoma. So it arises from the epithelial cells, most commonly renal pelvis. Sorry. The thing to remember is that there are two kind of basic types of primary kidney cancer. You got the renal cell carcinoma and the transitional cell. Okay? So if you see a tumor in the ureter, what kind of tissue type is it?
Transitional.
Transitional, good. Now there are some other ones that are much more rare, but that's basically it. Okay. All right, excellent. All right, who's next?
Danielle.
Danielle. Okay, tell me what kind of study we got, whether it has contrast or not. Tell me what all the arrows are pointing to.
This is a coronal CT. I would say that there's contrast because you can see the contrast. And I would say that we're pointing to a both kidneys and possibly a ureter.
Okay, so these are two different patients. You have
Okay.
this patient over here, this patient over here. So this is pointing to what here?
Kidneys.
So you've got kidneys. So are these normal looking kidneys?
I would say no.
No, why not?
The one on the right side, so
Yeah.
looks underlobulated.
So you see this dark area here,
Yeah.
and this one here,
Yes.
this one here. So these are multiple masses in the kidneys.
Oh wow. Okay.
So you've got bilateral multiple masses, and then what is going on here? I can tell you this whole big thing is a mass.
Okay.
This whole thing is a mass. This is the bone here. Normally there's a bone here, but it's eaten away. Got a mass that's just eaten away bone. What? How can you put this all together?
Well, if that's been eaten away, I would say that that's affecting the kidney's ability to filter. So now we have masses in the kidney because of this bone erosion.
Well, actually, it's the other way around.
Oh, okay.
You've got this cancer that's going on in these kidneys, and this is metastatic disease. That's metastatic disease. And then over here on these kidneys, what is going on here? This is kind of strange. Do you see a mass in those kidneys? Or they just look enlarged, or they just look like?
I'm not really sure. It seems like it's pointing, the top arrow is pointing at maybe something above, like the adrenal area. Maybe the
So
capsule
actually,
is a little thick.
this renal capsule is infiltrated.
Okay.
This is all the renal parenchyma. This is not normal enhancement. It's bilateral. So this is an infiltrated tumor. There's no way I would expect you to figure that out, except to look at it and say, this is abnormal. There's something weird going on. This one's a lot more obvious. It's the same disease. There is a cancer that affects almost any organ and can look like anything. And that cancer is this, it's lymphoma. And you can get masses, infiltrative, diffuse enlargement, or enhancement. So hit lymphoma can look like a lot of things. Would I expect you to be able to look at a CT and say, oh, that's definitely lymphoma? Absolutely not. But this is just to show you that lymphoma does affect the kidneys and it can look like anything. Okay?
Okay.
Oh, very good. Very good.
Thank you.
Yeah. And who is next?
Grace.
All right, Grace. Tell me the kind of study. And this is the most common type of cancer. So you can look at this and not even look. You don't even have to look at this image and tell me what the most common cancer is.
Is this a CT?
It is. What kind of imaging plan?
Okay.
Is this axial, coronal, or sagittal?
Axial.
Good. And I'll tell you, it's kind of hard to tell, but this is with contrast.
Okay.
What's going on here? What structure is this?
The liver.
And what's going on here?
Are there masses in the liver?
Yeah, so there's masses in the liver. What's going on here in the kidneys?
There's masses in the kidneys.
Good. What's going on here?
Are the masses growing out the renal?
Vein.
Did you say renal vein?
Yeah. So we have tumor thrombus. We got bilateral. We got multiple renal masses, liver masses. So now, what is the most common type of cancer? This is kind of like a generic question.
Renal cell carcinoma?
No. The most common, this is kind of like, you know what I'm at, think the same way I'm thinking. The most common type of cancer is metastatic disease.
Okay.
So, in fact, I think the primary in there, this may have been breast. But whenever you see multiple masses, the first thing you think of is metastatic disease. Now, could it be metastatic from renal cell? Could be. But most likely it's more like breast, lung, or something like that.
Okay.
So this is a case of metastatic disease and shows some tumor thrombus as well. So very good. Excellent. So lung, breast, GI tumors, melanoma is a common one. You can get tumor thrombus, which is also common in renal cell. Okay, very good. All right, who's next?
Jesse will be next, but Shaviante had a question. The not this last one we saw, but the one before that with the liver and kidney masses. That was renal cell carcinoma, correct?
The one we saw before, like way before.
I think it was the only other one. Yeah, was it this one?
Yeah, let's see. Let me go back. There's renal cell, renal cell, renal cell. Oh wait, I think that one. No, that was polycystic kidney disease.
Thank you.
Yeah, that was the one. It was polycystic kidney disease. Yeah. Yeah, it's actually pretty unusual for renal cell to see mets in the liver. Actually, it's unusual to see mets at all with renal cell, to be honest with you. But they do, it does metastasize, as we already discussed. Okay. All right, who we got next? Jesse?
Yes. Hi.
Hey, Jesse. All right, what kind of study? What's the finding?
CT.
Okay.
I'm not sure what the finding is.
Is this axial, coronal, sagittal?
Axial.
Good, good. Okay, let's just go over here. It's this kidney right here. This kidney is normal. Here's this kidney. We got this right here. What's going on here?
Looks like a mass.
Good. It's a mass. Now, you see the fat that's around there? Does it look a little hazy? Like this is nice and dark. This looks kind of hazy.
Yeah.
Good. So, what's your differential diagnosis?
Tumor, infection, trauma, or other.
Excellent. Okay. And of those, with a history, which one's more likely?
With the, what history? Sorry.
See the history up there? You see the history up there on the?
Oh, sorry. Yeah. Infection.
Yeah. So, what kind of infection? What would this be?
Hydronephrosis.
Well, hydronephrosis is not an infection. That means just dilation of the collecting system. But what kind of mass gives you an infection? You probably know it. I mean, abscess. It's an abscess. Good. So as far as infection in a kidney, you can have infection of the whole kidney, which is pyelo. The differential is lymphoma because it can look like anything. Renal abscess, which this one was. XGP, have you come across XGP in your studies? Aaron, you guys cover that?
It doesn't sound familiar to me.
Interesting.
Actually, yeah. I've like roughly gone over it. Like, I don't think we went into a whole lot of detail.
Okay.
Shaviante points out that it's in first aid.
Okay. So XGP is xanthogranulomatous pyelonephritis. It's uncommon infection. It happens in old folks, and you get these big stones, hydronephrosis and fat. I'll show you a case of it. This is a case of XGP. And though if you have a big one like this, it tends to get resected because it can bleed, or some people feel it's a chronic infection. It does not have any increased risk of carcinoma that I know of. But so now you've heard of everyone's heard of XGP, or xanthogranulomatous pyelo. Okay? And I'd have to look it up again. I think it's more common in diabetics, but I could be wrong on that. But it's usually and it's greater in females as well, I believe. Anyway, Okay. So who is next?
Kate.
Kate. All right, Kate. What kind of study is this, and what's going on?
This is CT with contrast.
Yeah. And this has IV contrast. It also has some oral contrast. But IV contrast. Here's the kidney. What's going on with this left kidney?
It looks shrunken or something, and I see something like a mass somewhere.
Okay. So this, this enhancement here, this looks pretty normal.
Wait. Okay.
Does that? I'm asking you. Does that look normal to you? This enhancement right over here.
I thought that yes.
Yes. How about over here?
That's the part I thought would be the mass.
Right. But does the rest of the kidney look pretty good? I mean, it's nice and sharp. Does it look like there's a mass here?
Oh, okay. It's sharp.
Yeah, it's sharp. Now, could this, like we looked at that transitional cell carcinoma, to me it looks almost identical. But this is a person who has a young person, but they got high blood pressure issues, and they come in with flank pain, and you get this scan, and you get the ultrasound. Ultrasound looks completely normal. There's no hydrophobia. You look at this, and you just don't get this enhancement. So, what's your differential diagnosis?
You mean like the tumor infection thing or something specific, more specific?
I mean that exactly. Whenever I ask you, what's the differential diagnosis? Tumor infection, trauma, or something else?
Okay.
Remember that. And so this could be a tumor, this could be infection, this could be trauma, could be any of those. But someone who's got flank pain and hematuria as an incidental finding, this kind of comes under the other diagnosis. And this is an infarct. Okay? And I actually see these quite often. We will do ultrasounds and we'll follow them up to make sure they go away. And most of the time they do go away. But you get a little thromboembolism that causes an infarct. You get infarcts in your heart, obviously a myocardial infarct. You get infarcts in your brain, which is a stroke. You get infarcts in your bowel, and you get infarcts everywhere, including your kidneys. Fortunately, in your kidneys, it's usually not a big deal. Unless you infarct the whole kidney itself. And that's usually traumatic, and then it usually be removed. But for the most part, it's fine. Okay? Anybody have any questions about that? Okay, good. All right. So, Aaron, how are we doing here? It's been almost an hour and a half.
Yeah, we have a review session at 3:00. So I think if we want to do lung, we might need to scoot forward to the lung, probably.
Okay. All right. Then I'll just chronic hematuria. You have this is a non-contrast study. These are a bunch of stones. Okay, kidney stones. Most commonly, they are calcified, which means unlike gallstones, which don't. They're usually multiple and bilateral. The places that they obstruct are the UPJ and UVJ. That's important. So this is proximal. This is distal. This is down by the bladder. This is right where the ureter starts at the renal pelvis. Okay. Here's the UPJ stone. Very, very, very common. This is a non-contrast study. You don't want to do contrast study because then you can hide the stone. This is trauma. We get a renal laceration. This is all blood. There are ways to grade renal trauma. For the most part, kidneys do very well and they heal up. They don't require surgery, but here's the grades of the different trauma. Okay, now we're going to switch gears into lung. This is a tumor. Here's a bunch of adenopathy. Most likely this is a stage 4 bronchogenic carcinoma. We're going to talk about this. Another type of mass, adenopathy, mass, post-obstruction pneumonia, another type of cancer. So the types of lung cancer, this is something that you all will be tested on, guaranteed. You got to know. Most common is adenocarcinoma. Now, remember, this is primary lung cancer. I'm not talking about metastatic, okay? It's primary cancer. Number one is adenocarcinoma. Next is squamous cell. And then in small cell, you have it's more of a systemic disease. And then large cell. So just remember this in general. This graph, I think, is really important, and keep things straight for you. Okay, who's next?
Back to Robert.
Hey, Robert. What kind of study is this, and what's the finding?
This is a chest X-ray.
Yep.
And the finding is, I don't know, increased vascularity.
Hey, no, there's a mass. There's a mass there. And once I point to it, be like, oh my gosh, but I have to agree with you. At first, you're like, I don't know what's going on.
Okay. Is it up like near the right apex? It looks a bit denser there.
Right here, that's it, perfect. So that is the mass right there. So there's a name for a lung mass that's in the lung apex. You know what that is? Named after a doctor.
Right, I used to, but I forget the name right now.
The Pancoast tumor.
That's it.
Pancoast, but it can be, like Pancoast could be squamous cell, could be adeno, could be metastatic, but it has problems because it affects nerves that come out of the spinal canal. So that's just a Pancoast tumor. And then what is going on here, Robert? Kind of study?
CT.
Of?
Is it a brain?
Yep. Very good. Very good. And I'll tell you, this side is normal. What's going on over here?
There looks like there's a mass in the middle.
Yep, there's a mass. It's got it's got bright edges. You see this darkness area here?
Mm-hmm.
That's cerebral edema. That's fluid. So what is going on? This is a person, that's the same person we were looking at before. What is that?
Is it a metastatic tumor?
Perfect. Excellent. And lung loves to go to brain. So that's a metastatic brain tumor. Very good. Okay. Okay. This is another case where we have a huge mass in the right hilar area, pleural effusion, elevated right hemidiaphragm, differential, tumor infection, trauma, other. In my mind, this is a tumor till proven otherwise. We'll do a CAT scan. So it mainly involves the pleura, and there's a big pleural effusion. Okay, and who is next?
Shaviante.
Shaviante. So we got a CT here. We got cancer of the thorax involves the pleura with a pleural effusion. What kind of tumor involves the pleura? It usually occurs in people that have been exposed to asbestos, mining.
Mesothelioma?
Mesothelioma. So this is a case of mesothelioma. Now this is unusual because it happens to be a 88-year-old female who did not work in the mines, but this is a mesothelioma. The primary neoplasm of the pleura. It's usually related to asbestos. Very poor survival, and pleural effusions are common. Good. Okay, and who's next?
William.
All right, William. What's going on here? It's very common cancer in a young patient.
Oh. I actually.
What's the finding?
It almost looks like, well, it's kind of a weird It almost looks like a left lung collapsed.
Okay, it's good. That's a good idea, but it's not. I can tell you this all right here. Here's the heart. Heart usually goes like all this is mass, all this is mass. This is all huge mass adenopathy.
Wow. Okay.
That's all adenopathy and mass in a 17-year-old female. What kind of cancer are you thinking of? That's common in a young group.
Just adenocarcinoma?
Nope.
For lung? I don't know.
Lymphoma, Hodgkin's lymphoma.
Oh.
Okay, have you heard of Hodgkin's?
Yeah.
All right, you guys will definitely get tested on Hodgkin's. Definitely. There's different types. You're going to know those way better than I. The key things: mediastinum, the Reed-Sternberg cells. Know that there is a bimodal age distribution. There's Hodgkin lymphoma. There's non-Hodgkin lymphoma. The different tissue types. So make sure you get those. That you know those. Okay.
Wait, can you go back one?
Yep.
To the picture. So is it taking up? So that's well beyond the mediastinum, and it's taking up most of like the actual thoracic cavity.
Yeah, all this right here is growing out. And I apologize, I didn't show you that I didn't show you CT. But yeah, this is really big. Lymphoma gives these huge, giant lymph nodes, obviously because it's a cancer of the lymph nodes. It's very impressive. The good news is it responds extremely well to treatment. Extremely well.
So it's pretty much going down to the cardiac silhouette that we're and kind of blending into it.
Yeah, all this right here is the mass.
Okay.
That's it. And it's the anterior mediastinum. And I know that doesn't mean much to you right now, but it will. So anterior mediastinum will be up there. Okay. This is a case where it just shows you pretty much have to pay attention to what's going on. There's this vague little infiltrate here that almost looks mass-like. If I would see that, I would call it infiltrate, and I'd say, well, maybe follow up. We follow up, and it's still there. And this is another type of cancer called bronchoalveolar cell carcinoma. It can look just like a pneumonia. And it's a bad actor. It's an adenocarcinoma, and it can metastasize. So if someone's a big-time smoker, you can't let that slide. Okay. All right. I'm going to try and get down here real quick and give you guys a break because I know you got something else coming. Who's next?
Next is Alex.
All right, Alex. This is it's important.
All right. So can you hear me?
Yep.
Hey, so either tumor infection.
What's the finding?
So there's like a mass. Like a mass. Yeah.
What's going on here? Looks like it's got a big footprint, right?
Yeah, some sort of like cavitation there.
Okay, perfect. That's exactly what I said. This is a cavitary mass. Okay. What's the differential diagnosis for a cavitary mass?
Tuberculosis. See what else?
You're getting too specific for
some
me.
sort of cancer.
Good. Tumor infection trauma? Yes.
Yeah.
But you're absolutely right. TB can cavitate, absolutely. A lot of things. So this could be an abscess or it could be a tumor. Okay. Can you tell the difference between the two on an X-ray?
I cannot. No.
Good. Well, neither can anybody else.
Okay.
So you're in a good company. So we get this. It's this is very thick wall. This turns out to be a big squamous cell. This is a big cavitary mass. It's a cancer. Okay. Now, to be honest with you, something like this extensive, I would not call an abscess, but an abscess can cavitate. Good. So that's squamous cell. Can be cavitary. Obviously, tobacco I just put this as an aside. Lung cancer screening is controversial. That's for another topic. Okay. All right. So Aaron, you take this one.
Okay.
Front view. Chest pain with dyspnea. So what's the finding?
There is infiltrate in the middle lobe, the right middle lobe.
Good. Is there adenopathy here?
It kind of looks like widened mediastinum. So.
It could be. It's kind of hard to tell. So you have this wedge-shaped infiltrate. What's your differential diagnosis?
With Tito, I would lean toward infection, possibly pneumonia.
Okay. How about a pulmonary infarct or PE?
Yeah, I could
absolutely
see that. Yeah,
absolutely. Well, it turns out this is a mass with post-obstructive pneumonia. So,
wow.
But you made all the right findings, and not only that. Oh, I'm sorry. I take that back. It's a mass. It also has these filling defects, which is what?
I'm not sure, to be honest.
These are in the pulmonary artery. These are emboli. These are pulmonary emboli.
Okay.
So she does have a PE. So she basically almost has all of the above.
Good night.
Okay. This is a case in the ICU. I'm going to open this up to anybody. Here's an endotracheal tube, NG tube, monitor leads. You've got these very diffuse, fluffy interstitial infiltrates. This is what a COVID patient would look like end stage. So what kind of diagnosis is this?
Are we looking at ARDS?
Yes, this is ARDS, ARDS. Okay. So, and that is a very frustrating disease to deal with. You just kind of cross your fingers and hope the patients will make it. Here's our pulmonary arteriogram, some of the ARDS, and you have all these fluffy interstitial diffuse disease. I don't know why I put that in there. There is a pneumonia that, in fact, I'm missing a slide because with varicella, well, with varicella, you got a bunch of tiny nodules, and it can become calcified, and you'll see that. And I apologize, I should have put another case in there. This right here actually is an end-stage varicella, but I use this as ARDS because that's much more of a teaching point, and that's basically what that is. Okay, that's it. Good job. Sorry for keeping you for so long, and good luck on your next session.
Excellent. Thank you so much, Dr. Vanderberg. We really appreciate it. And with your permission, I'll go ahead and share the slides with everybody as well. And we will wind up having the video available for everyone here too. I'll try to get that posted up later on GroupMe. All right. Thanks again, Dr. Vanderberg.
All right. Take care, everybody.